Our today's case is approaching siblings with a family history of sudden cardiac death and suffering from recurrent syncopal attacks. Is a female, 12 years old, complaint of recurrent loss of consciousness. The condition started with the first attack of syncope when the patient was 6 years old. The attack was at her home door. Her father stated that her heart rate was 243 beats per minute and oxygen saturation dropped to 35%, and she had convulsions during loss of consciousness. Her mother died at the age of 29 years old, sudden cardiac death. The father suffered from paroxysmal supraventricular tachycardia, and actually he underwent ablation. Her brother suffered from the same complaint of loss of consciousness and presented with her for further investigation. There is negative consanguinity between the father and mother. Examination of the 12 years old female was normal. Her resting ECG was a normal sinus rhythm. Her echo shows mid-systolic bellowing of anterior mitral valve leaflet and mild mitral regurgitation. This is the 12-lead ECG. Actually, this one of Dr. Mervet's case at her private clinic. Her first presentation. She's a 12 years old female.
ممكن نادي الصوت ده عشان نسمعك. ممكن تخلي بالك بس من الحته دي.
She is 12 years old. Okay. She is 12 years old girl. Her first presentation to us, as I told, she presented with recurrent syncopal attacks. The last attack was associated with convulsion during loss of consciousness, and there were no post-ictal confusion. When we approached the patient, she told us the attacks may be followed after exercise in front of her house gate while going to the stairs. So we discussed with her to make a 24-hour Holter monitoring, and we instructed her to make the same triggers of the syncope to go up the stairs and all that activity that preceded the loss of consciousness. The 24-hour Holter monitoring showed polymorphic VTAC ranging from a salvos of 3 beats up to a run of 258 beats, reaching 238 beats per minute, with evidence of bidirectional VTAC. And it was clearly noticed that the runs of ventricular arrhythmia coincided with the periods of physical activity recorded in the patient diary. This is the bidirectional VTAC on her Holter. This is the first documentation for ventricular tachycardia for this patient, despite years of syncopal attack and the history of sudden cardiac death of her mother. This is her Holter monitoring. Bidirectional VTAC most of the time, associated in the patient diary that she was doing activity at the same time of the ventricular tachycardia. Also, to confirm that this associated with exercise, we decided to make in the exercise stress ECG, and when we do the exercise ECG when the heart rate increased, it was associated with a bidirectional ventricular tachycardia. This is her stress ECG. Thus, the diagnosis of exercise-induced VTAC, catecholaminergic polymorphic VTAC, was done. The patient's brother, 11 years old, Holter, showed the same finding with lesser polymorphic VTAC burden. The patient started on propranolol 40 milligram daily, and we were discussing to make adds on either flecainide or propafenone, but she was controlled on Andral and reported no single syncopal attack I can show also her brother with the same history and examination. His Holter, his brother was younger, 11 years old. Same attacks with the Holter, and the stress ECG also show a lesser burden of bidirectional VTAC, but show traces of ventricular tachycardia and